Hi, I'm Mary Ann Smith, and we're going to talk about age-friendly healthcare and systems today, focusing on what matters most. So, our goals for today are to have a brief review of the 4M's age-friendly healthcare and what the healthcare system means, and then talk about some of our common care challenges that support why being age-friendly is important. Then we'll talk some more and in more depth about what matters most to older adults, why it's important to be person-centered rather than disease-focused, and how we need to align care to each person's goals and preferences, and the importance of having conversations across levels of care and types of care settings. I'd like to just briefly acknowledge that this program is one in a series of 8 programs about the 4Ms and is co-sponsored by the Some Center for Gerontological Excellence and the Geriatric Workforce Enhancement Program at the University of Iowa Geriatric Education Center. The content is based on age-friendly initiative of the John A. Hartford Foundation and the Institute for Healthcare Improvement. We really hope everyone will explore the link listed on this slide to learn more about age-friendly health systems and how you can be part of this very important social movement. I'd like to start with just a couple of acknowledgements. First of all, a lot of the content that I'm talking about today is based on existing expertise. The program sponsored by the John A. Hartford Foundation and the IHI offers a detailed manual about what matters to older adults. So the content draws heavily on this manual. I also think it's really important for you to visit the Patient Priorities website and think through what they are saying about what matters to older adults. So this program draws very heavily on each one of these websites. Please do visit both of them. There are just terrifically great materials and additional ideas to share and to use in practice that we would never want to try to replicate, but I certainly do want to highlight. So patient priorities care, this is another slide about recognizing the important work that was done by Patient Priorities Care. That was actually a starting point for the age-friendly healthcare movement that talks about how we align care with what matters to patients. Now, we've adapted that language a little bit to talk more about older persons rather than always in the medical context of the older person being a patient. But I will say this is just an excellent, excellent resource for how to have conversations with older adults about what matters, and then thinking about how we take that information and align their care and treatment to achieve their personal healthcare goal. So back to what is an age-friendly healthcare system? Well, that's where every older adult gets the best care possible. They experience no healthcare-related harms, and they're satisfied with the healthcare they receive. In turn, value is truly optimized for everyone. And the 4Ms are what matters most to the person: their medication use, their mobility, and their mentation, including dementia, delirium, and depression. The 4Ms is a framework. It's not a program, but a shift in how we think about providing care to older adults. There are lots and lots of good reasons to use the 4M framework. For starters, it is absolutely a best practice that works across all healthcare settings. So it's not restricted to one type of healthcare or another. It focuses on the person, and that's so important with older adults, not their diseases or their disabilities. And it really concentrates on their quality of life, not necessarily providing more treatment or offering more transfers for more care at a hospital or other treatment setting. It really thinks about what is most important to the person, and then how do we work from that? The big challenge, so the driver, why do we need the 4Ms? I mean, haven't we been doing a good enough job? Well, maybe not. The really important piece is that older adults are different from one another, and certainly the needs of older adults with multiple chronic conditions varies considerably. The one size fits all does not work for most older adults, nor does it work over time. What makes sense early in the older person's aging process may not make sense now. Their priorities change over time. It's really important for us to think about, where is the person now? This is a really, I think, important, slightly complicated, but important graphic representation made by Mary Tinetti, who is a leader in the patient priorities movement and a geriatrician at Yale. And in this graphic, I think it really emphasizes that older adults in their aging process move across a continuum where using disease-specific, evidence-based guidelines may or may not make a lot of sense. So when we're younger and we've got, 10 years or more of life ahead of us, fewer conditions, and we're basically fit and functional, all of those guidelines make a great deal of sense. But as our life expectancy starts to shorten, and the number and severity of the healthcare conditions that we have starts to weigh on our ability and function, we have less certainty about whether a disease-based guideline approach makes the best sense. That's where patient priority aligned care starts to make the very best sense. And certainly as we grow closer to end of life and our life expectancy is really shorter, there is a place to de-escalate treatment and think about palliative or comfort care and symptom management. So the point here is that the one-size-fits-all approach doesn't work for most older adults, and it certainly doesn't work as their aging progresses. Their disease states perhaps become more severe and complicated, and we begin to approach end of life. So it's very important for us to think about patient priority aligned care, or what matters most when persons have shorter life expectancy, more severe conditions, more frequent, more often, trouble managing them, and difficulties with their function. So in a what matters framework, we want all of our older adults to identify their health priorities. And then as clinicians, we translate those priorities into care options. So we think about what matters most, and we say, well, in that context, this would be a recommendation, that might be an option, so on and so forth. But the point is that care is aligned with the person's priorities. In the What Matters framework, we're asking older adults to direct the conversation. The question becomes, what matters to you? As opposed to, what is the matter with you? So it's really an important shift from a more disease-focused, what is the matter, to person-centered, what matters most to you? So the definition again of what matters is to know and align each person's specific health outcome goals and care preferences across health settings. So we want to know what's important, and we want to align care with those health care goals and preferences. And that fits across a diverse range of settings, everything from daily living and engagement at home to end-of-life care. It's also important to say, well, what matters often is paired with end-of-life care. This question is not just end of life. Discussing what matters is critical to advancing advanced care planning. That is absolutely true. And as the slide reflects, there are some really wonderful programs available today about having the conversation project that's featured on the slide. Wonderful materials about how do we think about what's important and how do we prioritize end-of-life decision-making. But the forum's framework is not just about end-of-life. It is a framework that we use to guide care and treatment for older adults that have multiple comorbidities and who perhaps don't want more treatment or more interventions or more trips to the hospital, and are really would like to focus on what's most important to them. So the idea of a health outcome goal is guided by the person's values and activities that really motivate them to sustain and improve their health. So it's very person-centered because everybody's values and beliefs about what's important to do and what isn't is different from one person to another. But when we think about those values and we think about what motivates the person, that can really help guide decision-making about what kind of treatment is really important to the person. So if we back that up and say, well, what outcome goal are we even talking about? We'll start by babysitting a grandchild. What would that take? Walking with friends. What does that take? Being able to get out in the yard and do your vegetable or flower gardening, or volunteering at your favorite charitable organization. What does that take? So the health outcome goal is what matters to me. What do I need for my health to do so that I can do what's important? And then we think about care preferences as being care activities that we're willing and able to do. So things that we're willing and able to do, and also, very importantly, things that we're not willing or able to do or receive. And I think that piece about what I'm not willing or able to do is incredibly important and too often doesn't come up in conversation with healthcare providers and in healthcare settings in conversation with older people. So here are some examples of care preferences. So I go for my blood work every month and, it's really not a bother. I can do that. Yep, I walk and I do my exercises that those physical therapists taught me. And yep, I do them every day. But these here medications, they make me so tired. I can hardly get out of the chair, let alone get myself to church. And I so want to get to church. That's so important to me. So when we think about care preferences and we offer options to older adults, we need to think about, is that really helpful to them? Or is it not helpful? Is it doable? What are their thoughts about how practical those things are and whether they're willing to take it on? So this conversation about what matters most is not a one-time deal. It's an ongoing communication that is really, built on the relationship with the older adult and the person's care partners, their caregivers. We can have those conversations during regular outpatient visits, during an annual wellness visit. Certainly, we want to have conversations about what matters when there's a new diagnosis or a change in status. Something significant has happened in the person's life. And during management of chronic conditions, and definitely during inpatient visits, and absolutely at the time of advanced care planning for end of life. And as before, it really is a team effort. This isn't something that I think most of us as healthcare providers want to do alone. We want to engage the nurses, the nurse practitioners, the nurse navigators, our physicians, physician's assistants, social workers, chaplains, community healthcare workers, and absolutely, we can use trained volunteers. So the argument that, oh my gosh, that just takes so much time, really doesn't fly. We need to take time to identify, understand, and document what matters so that it can be acted on and updated across care settings. There are lots of ways that we communicate what matters too. Lots of creative ways to share that. These are photographs that I lifted off of the IHI website that I think are just so remarkably clever and important to illustrate that communication among team members is so important. So on this whiteboard, you'll see the question of what matters, and there's the answer, circled in red. So it's very important not only to identify it, document it in a paper chart, but make it widely available to everybody who works with the older person and provides some aspect of care and treatment. Again, this is from our overview program, but I think it's really important for us to always continue to think about how we focus on healthcare as healthcare providers. But the truth of the matter is, when we're caring for older adults, we need to think about what is important to them in the context of their life and living. What gives them joy? What brings them happiness? What brings meaning in living? And we want to think about their health, not just the health care that they get from us, but their ongoing health concerns and their health conditions in the context of what would they like to be doing, what's important to them, what gives them joy, and then certainly the interaction with the healthcare team and the treatment of disease, illness, and conditions. So we start with life outside healthcare, and we explore the context, the person's priorities, their preferences. We ask questions like, what's important to you? What brings you joy? What do you worry about? What are some of the goals you hope to achieve before your next birthday? What would make tomorrow a really great day? And perhaps, what else would you like us to know about you? And then we take those ideas and we anchor them to the health that the person has and what they would like, and then the treatment that maybe would be provided. So in that context, we think about health status and care needs. We think about times of how that might change at the time of a new diagnosis or having to make decisions about additional treatment. How much is enough? Do I really want it at all? Changes in health status. I seem to be declining. Maybe now is this time to start thinking about fewer pills instead of more, change in residence or care location. And we frame our question around how treatment can facilitate, make it better, or get in the way, impede the person's abilities to do the things they enjoy or to attain a goal that is important to them. So there are lots of questions that we can ask and lots of ways that we can ask it. But to get at the health outcome goal, here are some examples that you might try out. What is the one thing about your health care you most want to focus on so that you can do the gardening or babysitting or volunteering was the patient's priority more often and more easily? If we could change one thing in your health or health care, what would it be? What would you be doing more of if we could accomplish this? What concerns you most when you think about your health and your health care? Some additional guiding questions that I think are very important in these conversations. What are your fears or concerns for your family? A lot of older adults are worried about being a burden. It's important for us to talk about that and talk about it openly. What are your most important goals if your health situation worsens? It's important to anticipate health may decline. Again, talking about it openly. What things about your health care do you think aren't helping you or that you find bothersome or difficult? These are questions, that question is rarely asked in the context of a conversation with a healthcare provider. And yet that is so incredibly important to open the door to conversation that allows the person to tell us what doesn't work, what isn't helpful, what is way too much to try to do. And then another very important question, is there anyone who should be part of this conversation about what matters most in terms of your health and your health care? We don't need to be uncomfortable about this. I think one of the things that Patient Priorities Care and both and the John A. Hartford IHI initiatives talk very extensively about is that we need to plan ahead. This isn't necessarily an off-the-cuff conversation. This is something that we plan ahead. We want to keep it comfortable. We invite the person to talk about what matters to them ahead of time. We ask one or more what matters questions. We listen really carefully. And I would say listening with intent is absolutely critical. Then we affirm our understanding of what the person is saying to us with a reflection or confirmation kind of statement. And then we work to incorporate what matters information into the care plan and again, share it with the team. I know this is a lot of words and it's very micro print and I really can't read it to you from start to finish. But it is one of the most beautiful examples that I came across in my reading about how to initiate the conversation. And so I'm going to paraphrase it. Just forgive me if I don't say it perfectly. But it starts with, as you know, you have several diseases and health problems that your other clinicians and I are trying to help you with. And we know different people have different opinions. And we would like to know what matters most to you. And that will help me and your other doctors and nurses provide the absolute best care and treatment for you. So I'd like to have a couple of sessions with you, about a half an hour long, and talk with you about what is most important to you about your health, what you think is working well, and what you find difficult or unhelpful. And if you agree, which I really hope that you will, we'll set up a time and have a conversation to talk about how we can provide the best care possible for you. Do you have any questions? So back to this idea, I think it's so important to say how we frame the question or how we focus the question really does matter based on where we are. Is it a new diagnosis? Is it because of change in status? Is the parent currently in the hospital? Have they just relocated across the country to live closer to a family member because of a death of a spouse or another loved one? There are lots of variability about how and when and why we might have a what matters conversation. So think about if it is in the context of hospitalization. Was it because they're in, trying to get rehab, long-term stay, end of life? And please understand, and again, I've put the little whiteboard up in the corner because I think that it really emphasizes that what matters most can be just as simple as feeling safe and calm, which is what the whiteboard says that was most important to the person while they were in the hospital. So obviously they were nervous, they were anxious, they were unsure. And so the point was they wanted everyone to help them stay safe and calm. Other priorities might be things as simple as managing pain in order to walk again, having time with family, being sure that I get to talk with the chaplain. The idea is that what matters can be very simple and it can be very complex. Here's another example. Again, this is a photograph that I borrowed from IHI from a slide set that I thought was just so perfect in terms of offering an example of obviously what matters to this particular older adult. In spite of being in an institutional environment, she has her best friend, her dog, with her. So in this setting, her dog really mattered most, and the setting is able to accommodate it. That's the kind of from very complex to reasonably simple accommodations that we may be taking into consideration as we think about what matters most to the older adult. There's also, I think, very important for us to recognize that what the person thinks is most important and what the clinical team thinks is most important may not always be the same thing. So we need to work to reconcile those differences. If we think that the older adult may not be understanding what we would like for them to do or recommend for them to do, then we want to back it up and make sure that we understand their perspective, that we understand their priorities, we understand the context, we understand their family concerns, they understand the burden of treatment and coexisting conditions, that we mutually agree on the health trajectory. We want to take some time and probably talk about trade-offs in an unbiased way. This requires that we get our opinions kind of pushed off to the side and try to be as objective about it as possible and stay really genuinely, truly person-focused. And we want to be really genuinely realistic about what the benefits of treatment are or the recommendations that we have made, if in fact the person is saying they don't want it. So if the person understands the alternatives, in many cases, the best next step is to accept their decision and try to work to accommodate care and treatment in the context of what is most important to the person. So again, everything spins around what matters most to the older adult. There are lots of ways that we can have those conversations, lots of places we can have the conversation. And what matters can be as simple as having my pet with me while I'm in the hospital or rehab setting, or living at home in my senior living accommodation. It may be as complicated as regaining my mobility so that I can walk my dog and go to church on my own. So lots of variation in how that might look. The point is that what matters truly is the driver. And then we think about their medication and how that might impact what is most important in their mobility, and certainly the influence of their mentation, a cognitive impairment, acute confusion, or overlapping depression that is robbing them of quality of living. So in summary, this is not a conversation. This is an ongoing series of conversations. And the aim is always to align the care and treatment that the person gets with their personal health care outcome goal and their care preference. Their health outcome goal and their care preferences. And we also need to understand that those goals can change over time. So we want to reassess, rethink, have a conversation again, revisit, and then we want to be sure that it is genuinely a team effort. Everybody should be involved in understanding what is most important to the person, what their health care priorities are, what their outcome goal is, what their preferences are. If they don't want to do it, we shouldn't ask them to. And document it, make it available, make it easy to understand, and be sure that then everybody is doing the same thing. So conversation skills are developed with practice. Please know this isn't something you just jump into. It has a lot to do with motivational interviewing. It takes some practice, but the evidence in the literature says that older adults want to have the conversation. Older adults are delighted to have someone ask what matters to them. And they may have to think about it a little bit and come back and give you an answer because it happens so infrequently. But it does guide care. It guides quality of living. It can reduce burdensome treatment. It can reduce frequency of healthcare visits that are not wanted. So there's just so much good that comes out of using the 4Ms and starting with what matters most. Thank you.